Hello, Nicolas from Mieghem here. I'm standing here with my good friend and colleague Joost Daemen, and we're broadcasting from the Cath Lab in the Thoraxcenter from the Erasmus University Medical Center here in Rotterdam. Today we're going to preview the American Heart Association meeting in Chicago next week. And as you all know, this is the last large cardiology meeting of this year, focusing on general cardiology, but also there are some interesting stuff from an interventional cardiology perspective. So that's why Joost and I will do this preview today. So Joost, 2 days of late-breaking trials, and the first day is on Saturday, the 10th?
Yeah, so the meeting will start on Saturday, November 10, with a series of late breakers. And I think the first trial that stands out to me that will be presented on Saturday is the ODYSSEY Outcomes economic study. So as most of you will remember, the ODYSSEY Outcomes trial was presented earlier this year during the ACC in March. And the trial actually showed impressive results. So they showed that if you randomize 19,000 patients to either the PCSK9 inhibitor alirocumab or placebo, this resulted in a 15% reduction in heart clinical endpoints, including mortality, at a mean of 2.8 years, very much in line with the Fourier study. Obviously, PCSK9, very expensive drug. So a year treatment with alirocumab is approximately $14,000. And if you extrapolate that and remember that the number needed to treat for MACE in this study was 29, that would imply that you need almost $1.3 million to prevent one MACE. But still, impressive results, and these drugs will change practice and outcomes. So I'm very much looking forward to this one and the economic assessment, which will be presented by Deepak Bhatt on Saturday. So more on Saturday?
Yeah, so different trials from all kinds, all segments in cardiology. One of the interesting ones is the CIRT trial, which is a study that focuses on anti-inflammatory effects and how you can improve major adverse cardiac events in high-risk coronary patients with immune suppressive therapy. One of those therapies is methotrexate, and so there's a randomized trial on 7,000 patients that was prematurely ended because the primary endpoint, or the answer to the primary endpoint, was already answered with only 4,786 patients. So I'm looking forward to the results.
Must be positive then.
I don't know, I'm not so sure. I think so far all the trials on immune suppressive therapy in this cardiac events have been somewhat disappointing. So it will surprise me if we would see a positive study. And also I have a hard time imagining that we would prescribe real immune suppressive therapy to our coronary patients. But that's why it's very interesting.
Yeah, I
agree. Another interesting slide, and this is more 2018, that is what would be the effect of yoga in patients after coronary events. There is a multi-center randomized controlled trial including more than 4,000 patients from India, where they are implementing yoga therapy in patients after acute myocardial infarction. I think it's quite an interesting premise to see whether yoga would be beneficial. We all know that cardiac rehabilitation in an organized setting makes a difference, but probably in India there is some cost issue to that. I don't think they have the logistics to get it organized in a big way for cardiac rehabilitation, but yoga obviously is very prevalent there in India. And interestingly, there's also in parallel a very small pilot study in the UK where they also want to test yoga physiologically and metabolically. So it's going to be curious to see whether yoga has some kind of effect, but my impression is that it will be a positive study. What do you think?
Well, that could be. I think it makes sense. I mean, it's in the line of, as you mentioned, 2018, with therapies a bit beyond the regular scopes, a bit of out of the box, and definitely in countries in which cost issues play a role. I think this could be positive, but let's see. It's interesting.
So those were 3 trials, late-breaking trials in the first day. So the second day is more we have a couple of more interventional kind of oriented trials, and maybe the first one is in out-of-hospital cardiac arrest.
Yeah, so the first session on Sunday will be focusing on acute cardiac care, actually, with a whole series of late breakers in this topic. And the first trial that will be presented, or one of the first trials at least that stood out to me, was the Princess trial. So the Princess trial is actually a trial which actually randomized 700 patients at the time of out-of-hospital cardiac arrest, so during CPR, to either nasal cooling, so directly with a rhinochill device, versus a conservative treatment in which the patients only got their cooling once in the hospital with the standard central venous cooling catheter. So this study follows on the positive results, let's say promising results, published in the PRINCE trial, I think about 8 years ago in Circulation, in which the same group of authors already showed that if you start cooling earlier, the time to cooling, at least the time to achieving or reaching the target temperature, is faster, which obviously is quite intuitive, it makes sense, but that trial did not show a difference in clinical endpoints. This trial actually is powered to show a difference in clinical endpoints, so I think it might change the way we treat out-of-hospital cardiac arrest in many sites in the world in which this device could be implemented. What I'm curious to see is if there will be adverse effects or safety issues, because in PRINCE they found that I think 18 out of 200 patients had either bleedings or other safety issues with this device in this, let's say, high-risk patient population.
But all in all, I think if we look at cooling in acute MI or in out-of-hospital cardiac arrest, data so far have been conflicting and controversial. So my bets are that it's going to be a negative study.
I think you might be right.
We'll see.
But let's see.
Another study in out-of-hospital cardiac arrest patients is the NEUROPROTECT trial, and this is an interesting one from our perspective because it will be presented by Koen Amelot. Koen is a colleague and an interventional cardiology fellow at this moment in the Thoraxcenter, but he designed with his colleagues in Leuven, Gasthuisberg, a trial where they were going for a more hemodynamic optimization in patients who were suffering from an out-of-hospital cardiac arrest. The study only enrolls 120 patients, so it's more like a pilot kind of study where they want to see whether a more aggressive approach aiming for a mean arterial blood pressure above 85 millimeters of mercury and a mixed venous saturation above 65% would make a difference in terms of outcomes in post-cardiac arrest survivors. I think this study is a little bit reminiscent of the early goal-directed therapies that we know from septic shock. Yep. Those trials, at the end of the day, were negative trials. I like Koen very much, but my bet is that it's going to be a negative trial. What do you think?
Well, I think I'm not so sure. I mean, the nice thing about this trial is, although it was small, there's a lot of focus on not only neurative cognitive function after, but mainly also on neurological assessment during the time the patient is still intubated and sedated at the ICU. So I think we will learn a lot from that trial.
Oh, that's without a doubt, without a doubt. Then next up, we have a couple of trials in the cath lab.
Yeah, so one of the first is T-Time, which is a randomized double-blind study looking at the potential effects of alteplase during the time of the primary PCI. So it's a study actually performed in Scotland, in Glasgow. It's also Colin Berry who will present the trial. And the idea is to randomize 440 patients to either recanalization using a wire, thrombectomy, and then randomized to either alteplase, low dose, 10 to 20 milligrams, versus the conventional dose we know from the fibrinolytic era in which we gave up to 100 milligrams. So it's really low dose given in the coronary, in the territory where the clot is. So it's also only patients with STEMI grade 0 flow and persistent ST elevation that will be included. It's again, let's say, a revival of this, the most recent generation thrombolytic, which is really fibrin directed, which might be most effective in the acute setting. So I think it's promising and it might be interesting. So this study will assess its primary endpoint between 2 and 7 or 9 days with MRI. Primary endpoint is microvascular obstruction, and actually the volume of microvascular obstruction as determined using MRI. So interesting concept, might be small and another step forward in an era where I think the treatment and improvement of care in STEMI has come to, let's say, stable level. So yeah, I'm curious.
I want to learn a little bit more details from that study, because I think the moment you start using thrombolytic therapy, then also vascular complications already arise on the horizon. So I think if they would make it mandatory to get radial access, that would make a difference as compared to femoral access, because then you might expect some vascular complications. So see what they're going to say.
That's interesting. In the protocol, they actually not make it mandatory, but at least strongly recommend radial access. So that is something they at least thought about. And the second thing is that, according to the protocol, they were not expecting any safety issues, because the safety endpoint was actually fibrin and measurements in fibrinogen, and not just bleeding or vascular complications. But you might be right, that it might be that the clinic shows different. So let's see.
And we are talking about more than 400 patients.
Yep.
So also the issue, what we often see in, for instance, pulmonary embolism, which is a different setting, and they use higher doses of thrombolytics, but always the brain hemorrhage is something that pops up all the time. Yeah. So it's going to be interesting to learn some of the details.
Let's see.
Okay, next on is another trial in non-STEMI.
Yeah, non-STEMI. So it's a study performed in Lille, actually, or amongst sites in Lille. Will also be presented by Laurent Bonello from Lille in France. And it's a study on optimal timing of PCI in patients presenting with non-STEMI. So it follows on a series of trials like VERDICT, like ICTUS, which all try to find a potential benefit of early stage PCI in patients with a non-STEMI. VERDICT actually was only very recently presented and showed that there was not really that much of a difference in patients that underwent early angio and PCI as compared to those receiving their cath only 12 hours or later, except for those with a very high risk. This study will add to that in a sense that it will really focus on patients that did not undergo preloading with aspirin and ticagrelor or prasugrel. So that, I think, is a little bit different than the previous studies. So let's see, the study will randomize 740 patients, so either undergoing angio and, if needed, PCI within 2 hours. So that is a very stringent time frame. I'm not so sure they will make that the majority. So that's to me, point number one I want to learn. And the second thing is something I do not completely understand, is that they decided to do the primary endpoint only at 1 month, in comparison to the previous studies, which did an endpoint at 1 year, or like VERDICT, even up to 4 years. So I think, to me, still a lot of questions on this trial. Hope to learn more. I'm
also a bit surprised about the short follow-up time. Yeah. I think 30 days for an early intervention trial makes me wonder.
Yeah, me too.
Next up is one of the highlights, or potential highlights of the trial, at least from my perspective. It is the door to unload trial. Patients with an anterior wall MI will be randomized to either Impella treatment and immediate recanalization of the occluded LAD versus Impella treatment and then a 30-minute unloading time window, after which the patients then will be treated with PCI and recanalization of the LAD. I think this is a very hot topic in the mechanical circulatory support world. A lot of advocates in favor, and it's all based on animal studies. There are also critics. I'm a little bit more critical. I still am raised and educated with the paradigm that when you have an occluded artery, you have to open it up as soon as possible. Time is muscle. They take it from a different angle. 50 patients is small, so it's a pilot study, but it will be hopefully the foundation of more and well-designed trials in the future for STEMI. But if I can make a prediction, I would be surprised whether we see positive results here. What do you think?
Yeah, me too. But the funny thing about this trial is that to me is that it's 50 patients randomized 1-to-1, but both groups got the Impella. So it's either so it's really, and that is also perhaps a nice thing, is that it very much it's clean, because it will just be the timing of the Impella in which there might be a difference or not.
But you miss out the third arm, right?
I missed this, the third arm, I agree.
But just imagine that this would be a positive study. Then that would mean at 3 a.m. in the morning you would implant you would first introduce the Impella, then go for a 30-minute coffee and then come back. That will be, oh my God. All right, so next on, the final study I think to discuss.
Yeah, so the final study, to me another interesting study on Sunday is TICAP. So TICAP is a huge randomized trial focusing on the potential efficacy of ticagrelor in patients with CABG. So it follows on a series of I think, at least 3 large New England trials. So Plato in patients with ACS, Socrates, patient with stroke, and also the Euclid study, the most recent one, in patients with peripheral vascular disease on the potential superiority of ticagrelor in terms of reducing ischemic endpoints. So interestingly, Plato, you all know, very positive trial. But then Socrates and Euclid actually were quite neutral, so no specific benefit of ticagrelor in these patients. This is the 4th in line, so it's a study, again, huge study. I think it's up to 3,900 patients, which were randomized either to aspirin or ticagrelor following CABG. So all patients were preloaded and then treated after CABG. And they all will be followed for vascular and let's say ischemic endpoints up to 12 months, my apologies. So I'm really curious to see if this 4th and potentially also last one of the big ticagrelor trial, because the drug will lose its patent soon, will be positive.
Well, interesting stuff. I think with this we highlighted 9 trials that will be presented as late breakers. There's much more to be presented in Chicago. Let's find out. We'll learn more 2 weeks from now, and I look forward to our wrap-up after the AHA and see whether our predictions were right or wrong. So with that, I'd like to thank you all for the attention and see you again soon. Bye-bye.
Bye-bye.